October 14th meeting of the Administrative Regulation Review Committee. Subcommittee will come to order. Secretary, please call the roll.
Senator Chambers Armstrong, Senator Rocky Adams, Senator Wilson,
Here.
Representative Bridges, Representative Gordon, Representative Marzian, Representative Lewis, Chair West.
Here. We have a quorum. First matter of business is approval of the minutes of the last meeting. Are there any additions or corrections to the minutes? Seeing none, is there a motion for approval of the minutes? We have a motion for approval and a second without objection, so ordered. Next on the agenda, before we get into anything else, I'd like to remind everyone, if you're here to speak against a regulation, for or against a regulation, we need you to sign up at the back, at the sign-up sheet on the back of dais there. Anyone have announcements or things they would like to add before we get started? Seeing none, we are doing something a little bit different today in this committee, and it's in the interest of saving time. We have a lot to fit in the time frame we're given today. So we are going to take care of staff amendments up front. We're going to do all the staff amendments for all the regulations up front and vote on those that way, and in the interest of saving time and holding quorum. Would you please call the staff suggested amendments?
The following regulations have staff suggested amendments: 103 KAR 25, 201 KAR 9 270, 201 KAR 20 161 and 410, 201 KAR 2220, 201 KAR 2375, 201 KAR 4681, 301 KAR 1 185, 241 83, 195, 230, 3120, 150, 51 and 522, 307 KAR 180 emergency, 601 KAR 2370, 803 KAR 2 250 and 260, 806 KAR 2 200, 210, 220 and 2030, and 810 KAR 760 and 80.
The staff suggested amend this group of regulations to comply with the drafting and requirements of KRS Chapter 13A and to comply with other governing law.
Are there any questions from members on the staff suggested amendments? Seeing none, is there a motion for approval of the staff suggested amendments? We have a motion and we have a second. Without objection, it is so ordered. Now that those are taken care of, we are going to get into our regulations. We are going to immediately go out of order. And first up on the agenda, we were going to speak about the Board of Medical Licensure regulations, starting with 201 KAR 9270.
Kentucky Board of Medical Licensure, 201 KAR 9270 with agency.
201 KR 9270 amends provisions to expand the exceptions to the required professional standards in specific circumstances and clinical settings, establish duties that may be delegated to a physician assistant, and eliminate physician licensure and education requirements and patient testing requirements no longer required by federal law. The agency amendment proposes to amend Section 3.2 to allow buprenorphine monoproduct to be prescribed to a patient diagnosed with opioid use disorder if the patient is transitioning from a full opioid agonist to buprenorphine, limited to a period of no longer than 30 days. And amend Section 3.4 to allow physicians certified in addiction medicine by the American Board of Preventive Medicine to be included among others qualified to provide specialty consult to patients.
Would you please identify yourself for the record? Make sure that green light is on there.
Gotcha.
There you go.
I'm Mike Rodman. I'm the Executive Director of the Board of Medical Licensure.
William Chase Thornberry. I'm the presiding officer and president of the Board of Medical Licensure. Mark George, consultant to the Kentucky Board of Licensure.
Thank you so much. There is an agency amendment. Are there any questions on the agency amendment? Seeing none, is there a motion for approval of the agency amendment?
So moved.
There's a motion and a second. Without objection, so ordered. So we have before us the Board of Medical Licensure regulations as amended by the agency amendment. The way we would like to handle this set of regulations, if you don't mind, is there's been a lot of back and forth between the parties over the last several months on this issue. If you could take some time right now, maybe 5 to 10 minutes or something like that, and please educate us, members of the committee, about what's the current state of the law, and then what this new regulation attempts to do or tries to do. Please.
So briefly.
Can make sure your green light's on there.
Hit the button. Hit the
Not
button.
yet.
There you go.
How about that?
There you go.
Okay. Not from a historical perspective, but we, in 2015, set out the standards for acceptable and prevailing medical practices for prescribing buprenorphine for treatment of substance use disorder. We first did that in 2015, and I think I can defer to our executive director. He can give you the historical background if you're interested in that. And then as that science and medical practice has evolved, we have amended it several times over the last several years. I think the last time we amended it was to include PAs. But the current amendments are really important because we are carving out exceptions for the regulation that it will not apply to certain settings and for certain treatments. So like the emergency room setting, patients who would come in and want to start substance use disorder treatment or to get buprenorphine in an emergency room, the regulation will not apply in those settings so that you can get patients initiated quickly. We're also carving out exceptions for cancer-related pain and certain things like that. There was a provision that if you were a female of childbearing age and ability, that you needed to have a pregnancy test before initiating treatment. That is now just a recommendation and is not a requirement. And I think that's pretty consistent. Dr. George could speak to that with the federal guidance now, is that that should not be a reason to delay initiation of treatment, but it should be strongly encouraged. Some other changes that we're doing are the X waiver. It used to be that you had to have a federally designated X waiver to prescribe buprenorphine. That's no longer the case. I think that happened a couple of years ago on a federal level, but it had been included in our regulation. We haven't been applying it over the past several years, so we wanted to tidy that up. We also wanted to clarify the education, that it's not additional education that's required. It's just a narrowing of the focus of education. So in House Bill 1 in 2012 and 2013, anybody who has prescriptive authority had to get continuing medical education in a number of topics. And then we have just mirrored that you have to also get that. And if you're going to do buprenorphine, those topics have to be more narrowly focused to topics related to addiction. Those are some of the highlights. So I think we're streamlining this regulation, coming off a lot of the overly burdensome things and clarifying some areas where we've seen some confusion over the past several years in application.
So what I'll do is the way this will go is I'll allow you all to finish. Anyone can speak on this and give us any information. Then I'll open it up to questions up here, and then there's some people signed up to speak against. Then I'll bring them up to present. And
Okay.
so feel free to take some more time if you feel we need further explanation
Could
on
I-
what's.
Could
Sure.
I allow so that the committee will understand? I'll have our executive director explain to you this process why we decided to open up the regulation and what we have been doing to get this before you today, because it's been about a 2-year process. So-
Absolutely. Feel free to proceed.
Well, back in November of 2023, we received a letter. The board received a letter from the Kentucky Society of Addiction Medicine, asking us to open the reg up, update it, maybe relax some of the items. The board, we initially talked about it in December, and December of 2023, we said, okay, we'll work on this. We'll form a committee. And in March of 2024, we formed a committee, a work group, which consisted of the the president, Kai Sam, who at the time, since he sent us the letter, we asked him to participate in this group. We also asked Dr. George, one of our consultants, to be part of the group as well, and along with Dr. Thornberry. And so they did a line-by-line analysis of the regulation. Once that was done, they made some recommendations, and we've never done this before, but we sent an informal a draft of the regulation to like probably 10 to 15 different groups around the state, any organized medical groups, asking for their comment and their input. And so then we did that. Then once that portion was complete, they went back and looked at all the comments, listed pros and cons, and then they decided in last December they finalized their work, and the board decided to go ahead and file the amendments. So we had one open comment. That's when the initial open comment period, and then later in the spring we pulled back and we had another full open comment period. So we've had basically three open comment periods to get input on this regulation.
Anyone else? Good. Any members have questions? Senator Rocky Adams.
Thank you, and I appreciate your all's testimony today. And this is one of the hard parts about this job, is because we are not physicians. We're asked to make decisions on things that we try to gather what is the best information that we can at the time. And so I do have a couple of questions. You all mentioned that you had 3 open comment periods. Did you make any adjustments to the reg as a result of those 3 open comment periods?
Yes, we made numerous corrections.
Okay. As members of the committee, I'm sure you know that what has gone around as far as the information, and that is, we received that the American Medical Association, the American Academy of Family Physicians, the Psychiatric Association, Addiction Medicine, Addiction Psychiatry, Kentucky Academy of Family Physicians, Kentucky Psychiatric Medical Association, Kentucky ACOG, and Kentucky Society of Addiction Medicine all say that the current language in this proposed reg would restrict access to buprenorphine in a manner that would needlessly perpetuate increased opioid overdose. So I don't know. And they recommend that the regulation needs more work. And so I don't know, and again, we're not physicians up here. We're trying to do the best we can with the information that we have. And we have you all saying that it's okay. And then we have experts that say it's not okay. And so, we have an opioid crisis in this state. We don't want to lose any more lives. And it's very difficult. We had legislation introduced last session that wanted to do away with this and this regulation. So can you see the conundrum that is before this committee?
Yes, Senator, and if I may, I'll say that you're referring to a joint letter that was dated September 4th that was sent. Mr. Rodman's already talked with you about the informal comment period where we reached out to these same organizations and received their input back in 2024. These same organizations provided written comment during 2 formal comment periods in 2024 and 2025. Also, we were scheduled to come to this committee last month. Representative Moser invited us to a meeting with these organizations and representatives on their behalf and asked us to defer from this committee so that we could receive additional comments, so a 4th comment period from these organizations. And we did. We took that back to our work group. We convened a special board meeting to take up those comments, and that's why we're here today. So we have heard these same comments over almost 2 years now from these persons. they are a very loud voice in the room. They are not the only voice in the room. And our board consists of 12 to 13 practicing physicians of various specialties, and they have weighed all of these comments and considerations. So I think you're just going to see that there are sometimes differing opinions in medicine. What do we know is working? We know that this regulation is working. And I'm going to let our board president, Dr. Thornberry, explain to you how we know this regulation is working, because it has been in effect since 2015.
Senator Adams, Mr. Chairman, I would like, the way I think about this is looking at empiric data. I think that the committee needs to understand a couple things about the regulation. First thing, if I was on the committee, what I would want to understand is exactly who's the regulation for. It's not for the addiction specialist in Kentucky. The regulation is written for the people that are on the front lines, and overwhelmingly, those are people that are not physicians, that have little or no experience in providing this care. Kentucky is not Iowa. It's not Idaho. It's not South Dakota. Those people, fortunately, do not have a terrible epidemic that we have. We're in a group of people, Florida, Tennessee, Indiana, West Virginia, Ohio, Kentucky. This group has a completely different risk factor. And so in medicine, if you'll give me a little latitude here, we have a concept called predictive value positive. If we have chest pain and we order an EKG, we need to understand what we're going to do with the EKG. If I have a young man out here doing physical labor that's 18 years old, he comes in with some point tenderness and chest pain. If I get an EKG and it's abnormal, do I really believe it? Well, our data says it's less than 1 in 25,000 is going to be a problem. Now, if it's an 85-year-old man who's out here with 3 bypasses, he's shoveling snow, he has chest pain going down his arm, and has an abnormal EKG, I'm going to handle that completely differently. And the teaching point here is that what might be good for some people or for the nation may not apply to us because we're in a special circumstance. We have these regulations because we've had a very, very difficult problem in our Commonwealth. We look at empiric data. So instead of somebody coming in and saying, well, everybody knows this, or someone that says, I've heard this, or let me tell you my story about this, maybe they may come in with some inflated credentials and you have no idea what the credentials are. We look at data that we can all agree on. So we look at, say, federal data, we look at data that we've collected, and there are a few data points that we can all agree on. And that would be one, the overdose deaths have been decreasing, and that's what the committee wanted us to accomplish. The last 3 years, it went down by 5%, last year 10%, this most current year down 30.2%. That is improving. The regulation calls for oversight of the dosage. The federal FDA right now has the concurrent dosage at about 16 milligrams. That's what we have in Kentucky. We've seen that decrease from when the regulation began at 32 milligrams down to 16, and that will treat 97% of the people. There are 3% of the people that it won't cover, and we have exceptions in Section 4 for those 3%. We do not let the exception write the rule here. As part of a concern of access to care, we had a concern about access to care, so we looked into that. I think what I could tell you is SAMHSA in 2021 said that about 22.1% of all the people addicted in the country had an opioid-related addiction. That's about 39.7 million people. Over the last 3 years, they've asked those people, why did they not get care? Was there a problem with the Board of Medical Licensure? Is there a problem with money or transportation? 95% of the people said that they didn't want care or didn't feel that they needed care. And you can take your calculator, but if you calculate that out, that's about 1.1% of the people that are actually saying that they want care that are not getting care. And of that 1.1%, 94% said, I know I need care, but I'm not ready to get it yet. So what you're beginning to talk about is this access to care issue is a rounding error. We don't see that in Kentucky. In the last 3 years, 3 to 4 years, we've seen a 14% increase in the number of providers. As a matter of fact, I think you can make a fair case that given our telemedicine regulation that was passed here in 2018, that we probably have all the providers that we need, because if we need any more, people are more than happy from out of state to provide telemedicine for buprenorphine. So we don't see that access to care. We see that really as a fallacious or a mythical argument. We're not seeing that here. And so all the empiric pieces of data, the overdose death, the number of providers that we have, the people that actually need care, all these things are going in the correct direction. If I would make an analogy, I would say that you've asked us to build you a ship to get us out of this terrible storm, and we've done that. And all of our metrics are saying that we're sailing in the right direction. Now, you may decide you want to jump off the ship in the middle of the ocean in shark-infested waters, and there are movements of people that would benefit if we have no regulation, or if we have lots of people getting buprenorphine and they never get off that drug. There's going to be people that benefit from that. But if you and a few friends do that, that's one thing. But if you're in charge of the entire ship and tell the entire Commonwealth to get off of this regulation that has brought us out of this scourge, and things go the wrong way, somebody's going to have explaining to do to the press and to the people. At this point, we see that we're going in the correct direction. All of our metrics tell us we're going in the correct direction. We listen to these comments from other people, and we respect the comments. And our specialists, we have 4 people on the board that are certified in this area or supervise this area. We've taken every comment very seriously. However, and I'm sure I'm speaking for the entire board here, there is a line of patient safety that we're not willing to cross. Our entire position is to protect the people of the Commonwealth. It's one thing if you want to step off the curve and maybe even take a misstep. It's another thing by dropping off a 2,000-foot cliff. And what we're saying to you, Senator, with all due respect, is we see a very substantial risk here, and we're not willing to move past what we've done. We've come as far as we can, and we've come a long way, almost every part of the regulation. There are a couple of pieces that we do not feel the science backs for Kentucky, and so we're going to hold firm on that area. My apologies for the extended discussion.
No problem. Thanks for the information. That's what we were looking for. Any other members have questions at this time? Okay. Seeing none, if you guys would step back for just a second. I'm going to bring, there are 5 people signed up to speak against. I'm going to bring you guys up all at the same time. And we're going to try to keep this segment to about 10 minutes. So I've got James Murphy, Dr. James Murphy, Dr. Colleen Ryan, Benjamin Bowling, Andrew McCochie. I apologize if I butchered that pronunciation. And Benjamin Wright. Benjamin Wright. If those people would step forward at this time. What we're going to do once we get started is we'll start on my left and just start. You'll have to introduce yourself for the record as we go down the line. If you guys, we need to keep this to about 10 minutes. If you guys want to negotiate with who has what amount of time, feel free to do that. But just everybody, are we ready? We think? Good. Okay. We'll start over here to my left.
Good afternoon. I want to thank the subcommittee for letting me speak today.
Let's introduce ourselves first. So if you would introduce yourself for the record, and then we'll go down the line.
My name is Benjamin Bowling. I'm a medical student.
My name is Benjamin Wright, small business owner.
I'm Dr. Colleen Ryan. I am the president of the Kentucky Society of Addiction Medicine.
My name is Dr. Drew Mitchell. I'm an emergency medicine provider at the University of Kentucky.
Okay, thank you. The floor is yours.
Thank you again. My name is Ben. I'm a 4th-year medical student at the University of Louisville. I did my undergrad at the University of Kentucky. I also completed a medical student fellowship last year on substance use disorders in Pittsburgh. I had the opportunity to speak with many people battling and treating opioid use disorders and the kind of barriers, stigma, and struggles that come along with it. I'm also currently applying to psychiatry residency this fall. I grew up in southeastern Kentucky in Bell County. This is a part of the state where they have firsthand seen how addiction and opioid addiction in specific can devastate families and communities. I have close family relatives who have continuously struggled with substance use disorders, and most people where I'm from have similar experiences. One of the main struggles, especially in rural areas, is lack of access to proper care. As someone preparing to enter psychiatry, I'm committed to serving Kentuckians struggling with addiction and mental illness, especially in underserved areas like Bell County, my home county. That's why I'm here today, to support updating or repealing 201 KAR 9270, the buprenorphine specific regulation. The intent behind it seems to be to prevent overprescribing, and the board is still defending this regulation. But the reality is that this regulation now prevents many physicians from providing life-saving treatment for opioid use disorder. Buprenorphine is a proven, evidence-based medication that reduces overdose deaths and helps people return to stable, productive members of society. Yet in Kentucky, it is regulated far more strictly than other Schedule III drugs, and this creates unnecessary barriers to care. Requirements such as excessive urine drug screens, rigid visit schedules, and dose limits below FDA-approved thresholds actively discourages physicians from offering treatment and deter patients from seeking it. Major medical and regulatory organizations, including SAMHSA, FDA, the DEA, and the Federation of State Medical Boards, have all called for expanding access to buprenorphine and bringing state regulations in line with current federal guidance. Unfortunately, Kentucky is one of the few states remaining that has a separate restrictive set of rules that contradict those very recommendations. In my view, and in the view of groups like the Kentucky Society of Addiction Medicine, this regulation is outdated and counterproductive. Addiction is a chronic medical illness. It deserves to be treated with the same flexibility and clinical judgment as conditions like diabetes or hypertension. Our regulation should empower and not punish physicians who want to provide care for these patients. We also need to think about the future of physician workforce in Kentucky. We want to keep our doctors here. Young physicians and future physicians like myself are much more likely to stay and serve the Commonwealth when we can practice true evidence-based medicine with reasonable oversight, but minimal interference from these kind of outdated regulations. When regulations make it harder to deliver patient-centered evidence-based care, it doesn't just harm patients, but it discourages physicians from building their careers in this state. If we truly want to reduce overdose deaths, strengthen our healthcare system, and keep our doctors in Kentucky, we need to trust the evidence, trust the physicians working on this stuff every day. I urge the board to consider repealing or substantially revising this regulation to align with national standards and support Kentucky's ongoing effort to combat addiction with evidence, compassion, and common sense. Thank you.
Hello. Good afternoon. I'm a little nervous. Sorry, guys.
Take your time.
Good afternoon, everybody. My name is Benjamin Wright. I'm a disabled combat vet, a business owner, a man in recovery, and someone who's walked through the kind of hell that no human being should have to crawl through twice. In just 5.5 months back in 2010, I was prescribed 1,760 oxycodone, 443 methadone, and 33 fentanyl patches. That's not a typo.
If you could speak into that microphone a little bit, we'll hear you better. You're good.
In just 5.5 months back in 2010, I was prescribed 1,760 oxycodone, 443 methadone, and 33 fentanyl patches. That's not a typo. That's real. That's the reality of the opioid epidemic. I didn't find addiction in some alley. It was handed to me on a prescription pad with a smile. I remember going to my doctor, admitting I was addicted, begging for help, telling him I needed rehab. And instead of sending me to treatment, he refilled my prescriptions 3 weeks early and sent me home. That wasn't medicine. That was neglect. That was profit over people. All of that happened because I came home from Iraq as a disabled combat vet, because I gave my body and my mind for this country, and this country's answer to my pain was poison. Then came prison, 10.5 years of it, and when I got out, the world had changed. It wasn't oxy anymore, it was fentanyl. The faces changed, the dealers changed, but the despair didn't. The crisis evolved, and the government didn't. It took many failed attempts. It took one person who refused to give up on me. It took buprenorphine through Medicaid for me to finally close that chapter. That medicine, that access, and that love saved my life. So when I hear politicians talk about cutting Medicaid and gutting SAMHSA and slashing harm reduction and treatment programs, I don't hear budget talks. I hear obituaries waiting to be written. They call it the one big beautiful bill, and I know I'm a little off topic for here. But
We're used to it here. Please proceed.
They call it the one big beautiful bill, but there's nothing beautiful about cutting health care for people still fighting the battle I barely survived. And let's not forget the same government that helped the Sackler family flood America with painkillers now wants to pull funding from the cleanup. That's like lighting a house on fire and then billing the survivors for water. I've seen what recovery can do. I've lived it. I've started my own company. I give back to my community. I mentor others, and I try every single day to be a part of the solution and not the problem. And if someone is no longer destroying themselves or the world around them, if they found peace, purpose, and stability, no one, not a politician, not a system, has the right to take that away. Because this isn't politics, this is people, and I'm one of them. For a long time, the only thing the world knew of me was a mugshot. That was my identity, my label. But because of those medications, because of Medicaid, and because of the love and support of family and friends, and the government I once fought to defend, I finally needed a headshot.
Thank you.
It's hard not to feel emotional when you hear that. So, as I said, I am Colleen Ryan. I'm a psychiatrist by training. I became board certified in addiction medicine in 2018. And I will say that being involved in policy and testifying in front of subcommittees is not necessarily my favorite thing to do. So I'll try to condense this. It's hard to condense such an important topic, but first of all, I want you to know I have the endorsement of the KSAM board, Kentucky Society of Addiction Medicine board, and we have the full support of the American Society of Addiction Medicine leadership in what we're saying today. I sent material yesterday. What I sent yesterday outlines that there are still a number of inconsistencies that make this regulation unsuitable to move forward. You can read what I sent. I think you will notice the Appendix A, as Senator Rocky Adams referred to, is signed by 6 national organizations and 4 state organizations. They do not do this lightly. They don't sign these letters without thinking about it. They are supporting us. I'm just going to go over a couple quickly of the inconsistencies. There are many, but language matters. One issue is that these are guidelines. Even the national, the Substance Abuse and Mental Health Service Administration put out is called TIP 63. It's a guideline. When you try to turn guidelines into rules, that's where you run into trouble because physicians need flexibility. There's always a patient who does not fit the mold, and there are a lot of patients with opioid use disorder who don't fit the mold. A couple of things, for example, KBML says that the proposed regulations require only good faith efforts to obtain prior records, but in reality, what the regulation says is it requires best effort, which is a higher legal standard. That might seem minor, but language is important because this is a rule we have to follow. Another thing is they are very insistent that patients need to be in some sort of behavioral modification. Studies on behavioral modification are mixed. We think it's important, but not everybody is going to engage in behavioral modification initially. And what happens when physicians see this as a rule is it leads them to feel that if the patient is not going to their therapy, they've got to discharge them from the clinic. Now, KBML would say, well, we really didn't say that, but they didn't say that you don't have to discharge them from therapy. So you need to have a statement in there that if patients are not going to therapy, you don't discharge them from their medication. And again, the guidelines were meant to be recommendations, not hard and fast rules. One of the reasons we're here today is underlying this whole thing, there's still a tremendous amount of misunderstanding about Suboxone, about how it works, and about addiction itself. That's true within the medical profession, and I think it's, I even see shades of this when I read statements from the board. For example, I'm just going to talk about a couple of these real quickly. The board in some of their statements has talked about we don't want to perpetuate addiction. We don't want to perpetuate dependency. Okay, that's a philosophy. When I first got involved in the field of addiction medicine, I felt like this was probably about 15 years ago. It was kind of a Wild West. I mean, people just sort of made decisions based on old perceptions, on opinion. We've got actual evidence now. The research has exploded in the last 5 years. So we really don't have to rely on opinion, but you still see this a lot. One of them is that somehow Suboxone is trading one addiction for another, and people shouldn't be on it forever. Some people don't need to be on it forever. People who have been deep in addiction for many years may need to be on it for a long period of time. You know, people are fearful of going back into that madness. And if I have a patient who tells me, who feels that they need to be on Suboxone for the rest of their lives so that they can still be productive and not go back into the madness, I respect that. I think they should be applauded for that. But you know what? They get shamed for it. They're told that they're not really sober. So when you say things like, we don't want to perpetuate dependency, that's kind of what you're saying. Physiological dependence is a property of many medicines, including benzodiazepines and antidepressants, things that are not necessarily a controlled substance. I want to really quickly address a couple of other issues. The issue, I know that the board is concerned about pill mills and diversion. Back in the day, we probably did have pill mills. You know, there was a time when Medicaid didn't pay for Suboxone. There was a time back in the opioid crisis when, yeah, there were probably pill mills. But remember, we have KAR 9260. We do have a regulation. KAR 9260 does regulate Schedule 2 and 3 controlled substances. Suboxone is Schedule 3. Schedule 2, those are the ones that cause the problem in the first place. So Suboxone is a much safer medication, but we have regulations that make it, you know, if we think there are pill mills, so let's do a study and find out how many instead of just saying, well, I think we have pill mills. Let's actually define what a pill mill is and do some studies. I work in a clinic. I know that it takes a lot of guts for people to walk into a clinic knowing what they're going to have to face. I also know that we're only treating about 30% of people with opioid use disorder. 70% of people with opioid use disorder are still out there. This is where a lot of the diversion is happening. It's happening among people who are opioid dependent and either they don't have Suboxone or they're in withdrawal from their fentanyl or heroin, so they're using Suboxone. We need to get those people into treatment. I mean, we know that. We don't want them diverting. We need to get them into treatment. But they're not your typical patient. They're not gonna just walk in a clinic door and come once a week and get urines once a week. They're much more complicated, but they can be treated and they are costing money. These are the people who are going in and out of ERs. These are the people who are on inpatient units. with being treated for serious infections due to IV drug use. So they are costing money. This idea, yes, if you ask them, they will say, I don't need treatment. I don't want treatment. Okay, I'm a psychiatrist. I've spent my entire career dealing with treatment with people who don't want to see me. I understand. I mean, nobody wants to see a psychiatrist, right? So I get that. You have to look below that. I mean, you cannot accept that at face value. When people say that, that's hopelessness. That's fear. Their brains are messed up. I mean, when people have been in addiction, their physiological changes, they're not thinking clearly. The thinking part of the brain is offline. So, you know, as physicians, we have an obligation to work with those people, but you can't do it without some flexibility. And the last thing I want to say is there's no connection between our regulations and the fact that the overdose rate has dropped. This is a national trend. It's not just Kentucky. There are a lot of speculation about why it is. The presence of naloxone may be part of it, but it's not related to regulations. Some states have had more drop than we have. Some states have had less. States that don't have any Suboxone regulation have had. So it's a complicated picture, but it's not related to our regulations. Thank you.
Hey everyone, my name is Dr. Drew Mitchell, emergency medicine provider at University of Kentucky. I'll try to keep this a little briefer than intended. I know we're strapped for time. I'm board certified in emergency medicine, medical toxicology, and addiction medicine. I've never really participated in this sort of like legislative discourse before, but upon reading this regulation, I was really concerned about some deficiencies in it, and I felt it'd be irresponsible not to urge some reconsideration. As a medical toxicologist, one of my main jobs is like studying drugs, both prescribed and not prescribed. And as a practitioner of addiction medicine, there's no drug I've studied more, honestly, than buprenorphine. And it's hard, as we're talking like side effects, therapeutic profile, efficacy, and it's really hard to overstate the astonishing safety of buprenorphine, pretty much regardless of where it's administered, and its efficacy for the treatment of opioid use disorder, regardless of whether psychosocial therapies are provided. I think the concerns about buprenorphine's safety are a little bit overblown and have resulted in some barriers, some proposed barriers to outpatient treatment that are somewhat misguided. It would make access to buprenorphine unnecessarily difficult for a lot of patients. One aspect of this is like the bias against non-office-based induction. I mean, generally patients need to be in some degree of opioid withdrawal to start buprenorphine. A lot of times the time course of opioid withdrawal does not coincide when a patient may be in front of a provider in a clinic. And when patients are in withdrawal, that's arguably one of the most dangerous periods of their life. If they don't have access to buprenorphine, they will likely use fentanyl or other opioids to treat their withdrawal. And allowing them to be able to treat their withdrawal in the comfort of their own home when they need to be treated is extremely important and is a major risk reduction measure. And I think is something that should be reconsidered in this regulation in terms of how we discuss initiation of buprenorphine. Specifically in relation to my practice in the emergency department, I think I can speak to a couple things. One is the use of buprenorphine in the community, in the pre-hospital environment. I'm not sure if this issue has been discussed in relation to this regulation, but Jessamine County EMS was starting patients on buprenorphine in the community that were in withdrawal after being reversed with Narcan after near-fatal overdoses. As I stated earlier, that period for that patient after being reversed with Narcan and not wanting to go to the hospital is an extremely dangerous one. And the fact that Jessamine County EMS was able to initiate and propagate this very forward-thinking and I think important program where they were both treating acute withdrawal, protecting somewhat from future withdrawal by the partial agonism of buprenorphine, and providing like a bridge or a lifeline to continued outpatient therapy was major. And they have since discontinued that program due to concerns over the legality based on how this regulation was written. They were planning on spreading it to surrounding counties, including Fayette County, and now we have patients who are being reversed with Narcan in the community who are not getting buprenorphine, who might want buprenorphine because of the way that this regulation is written. And I think that's honestly a tragedy. And I would hope that this regulation would be amended to reflect that issue and maybe provide some clarity for paramedics that they are acting in accordance with regulations, because I think this is something that they should be able to do. And then in the emergency department, I'll finish by saying I look at the emergency department as honestly like some of the front line of the opioid epidemic. Up to 10% of patients that present to the ED have substance use disorder of some kind. We see every week patients presenting after near fatal and fatal overdoses, in acute withdrawal needing emergent management, and who have sequelae of drug use such as infection. And sometimes I feel like the most benefit I could provide that patient is starting them on buprenorphine. Sometimes starting someone on buprenorphine is honestly the most beneficial thing I might do in an entire shift. And that comes with faith and trust in the system that they're going to be able to follow up as an outpatient for continuation of buprenorphine. And right now, every week, we see patients returning to the emergency department that we started initially on buprenorphine who are back in the emergency department because they can't establish outpatient follow-up for their buprenorphine for continued prescribing. And I worry that with this regulation, that will only become more difficult. We see statistics that are saying that the opioid epidemic is improving. I would say that from my perspective in the emergency department, it's hard to see that change. Things still seem very grim. And I think that if we are reporting to make all these improvements, it seems kind of counterintuitive to our whole approach to the opioid epidemic to try to make access to buprenorphine more restrictive. And so I really urge you to reconsider this. I think it would do more harm, I think, to the Commonwealth than benefit. And I think if it's passed the way it's currently written, it really be lamented in the years to come.
Thank you so much for that presentation. At this time, we're going to open up the floor to questions. If y'all want to stay there just a second, Do any members have questions for this group?
I think Dr. Murphy signed up to testify as well.
Okay. If you could come forward and testify briefly, if you could do just a couple minutes, I'd really appreciate it.
Thank you. I apologize. There's just 4 chairs up here. Thank you for the opportunity to speak, and I will try to be as brief as I can. I really appreciate the fact that you're here, you're present, you're listening, you're taking this all in. This is such an important issue. As you know, this was originally scheduled for yesterday, for Monday, and just last Friday it was rescheduled to today. There's also an opioid summit going on in Louisville the last 2 days, including today. A lot of people wanted to be here to talk about this. A lot of people wanted to testify, and they can't because of the changes and whatever. So I really appreciate the people that came, and I appreciate you being here as well. It's very, very important. Just a little about me, just briefly. I'm a pain specialist. I'm an addiction specialist. I'm a anesthesiologist. I'm a professor at the University of Louisville School of Medicine. I teach addiction to medical students. I serve on the board of directors of the American Society of Addiction Medicine. I work with the American Medical Association, the Kentucky Harm Reduction Coalition, and other groups as well. This is a subject that really, really is important to Kentucky, and probably something that we didn't know existed. We didn't know this problem really existed, but I'm so glad that it's getting the light of day. And I'm so grateful to the people that have come forward and talked. So I can't expand really much more on what they've said, but I do want to talk a bit, just for a minute, about the process here, because clearly the board of medical licensure, they feel like they're right about this. They're digging in. They clearly believe that they have the right answer to this, and they are honorable people. There's a 5-person work group that put this regulation together. 4 of them are here today. The only person not here is Dr. Tran. So you got 4 of the 5 people at the medical board here today. They're honorable people, and I'm sure that they believe in what they're saying. But there's 3 red flags that I can't get beyond in this process. Number 1, there's conflicts of interest that haven't been discussed. There's been misrepresentation of facts. And there's been really disregard for medical expertise in this field. I'm going to be brief with this because I don't really need to say much more. I will say that people are not empirical data. People are not statistics. people dying in record numbers in this state don't fall into some category, a check in the box, or any one-size-fits-all regimen. And that's what this regulation does. It forces doctors, the ones that have the courage to go ahead and treat addiction, it forces them down this pathway, and it eliminates a lot of patients that could otherwise be helped. You heard of the organizations that support removal of this regulation or overhaul of this regulation. I mean, it's amazing. It's unprecedented. The American Medical Association, the American Society of Addiction Medicine, the American Academy of Psychiatry, the American Academy of Family Physicians, the American College of Obstetrics and Gynecology, the American Psychiatric Association, and their Kentucky counterparts. I tell you, that's about 500,000 people that those organizations represent. 500,000 people. This regulation before you was put together behind closed doors by a group of 5 people. 4 of them are here today. 5 people. They had the public hearing on Zoom. Not a single board member showed up to that public hearing. Not a single board member. On October 4th, there was another Zoom meeting. They only had 8 board members that showed up. None of them, except Dr. Thornberry, said a single word. There was no discussion, no deliberation, and one of the members actually left before the meeting was over. Nobody else attending the meeting, including myself, got to speak. We were muted. 500,000 versus 5. We simply cannot let the future of addiction treatment, something this important in this state, be dictated by a group of 5 people, most of whom don't have expertise in addiction medicine. An administrator, a lawyer, a family practice doctor who doesn't have training in addiction, and 2 addiction specialists, all of whom may have some conflicts of interest. We need to get this right. We need to get it right now. If you want to know some statistics, the one you should just remember is 500,000 versus 5. Please, this regulation is not ready. Please, let's send it back to the medical board for more review, for more work, and let's get this right. Thank you for your time.
Thank you so much for your presentation. If you would stay there just a second. Does any member have a question for this group? Representative Marzian has a question.
Just for clarity, and thank you so much for testifying. So Suboxone is a once a month IM injection. Is that correct?
No, Representative Marzian. Suboxone is usually once daily.
Oh.
Yeah, it's a sublingual dose. It's a pill or a film that person can put under their tongue and take it once a day. That's for addiction. You can take it other times during the day or more doses if you have other conditions or if it better suits your needs. But primarily it's a once a day medication for addiction.
And you have to be followed by an addiction specialist.
No, you don't actually. As of that was never the case, actually, at all. And in 2022, the federal government eliminated all of the federal regulations regarding that. So you talk about we've had more prescribers in the state. We went from having about 300 to 400 prescribers in the state overnight to having about 5,000 potential prescribers. But the numbers have not gone up substantially, even though we have so many more people that can do it. They don't want to prescribe it because of barriers, and one of the barriers is this regulation.
And one last question.
Please proceed.
Thank you so much. Thank you for clarifying that, because I thought it was an injection all along.
Well, there is one form that is an injection. It's not called Suboxone, but it comes in various forms. It's also a good pain drug. Frankly, it was developed for addiction right up here in Lexington at the federal hospital back in the 70s. That's where a lot of the research was done. So a lot of the research was done right here in this neighborhood.
Wow. So the regulation we're looking at now would make it more difficult for folks to get treatment. Pretty much is what you're saying.
More difficult, more expensive for the patients as well, and put restrictions and barriers on them, responsibilities that actually make it quite challenging for people to stay in treatment.
So just for clarification on that, this is a personal question. So it was my understanding that the existing regulation is pretty restrictive, okay? And what the cabinet or what the board is proposing makes it less restrictive. But you guys are stating it's not opening it up enough. Am I wrong in thinking that way?
Well, you've heard the old statement, the Lord giveth and the Lord taketh away.
Sure.
Well, they've made some improvements to it. I'll grant them that, and we appreciate that. And they've corrected some typographical errors, and they've made some things more clear. So in some respects, it's better, but in other respects, it's harder and more expensive. You know, for example, the urine drug screens. They require so many urine drug screens, and they've added the number of substances that need to be tested. And that's expensive for somebody to do. And if you don't have the insurance or the ability to pay for those drug screens, and they're required, a doctor might kick you out of the practice. And then, addiction's a life-threatening illness. It's still the number one cause of death for people in this state under the age of 50.
Thank you. Senator Adams has a question.
Do you think, and this might not be an appropriate question for you all, but do you think that if this committee asked for this to go back and be discussed more, that it would be fruitful conversations, or do you think that it would be a stalemate again? Do you think that it would be do you think that you would get anywhere? Do you think the conversation would be fruitful?
Could I ask our president of the Kentucky Society of Addiction Medicine to answer that question?
I really think that depends.
Can you turn your microphone on?
Okay.
Is there any room for compromise?
I believe that there could be, but we do need to have a larger work group. It doesn't just have to be people from Kentucky Society of Addiction Medicine. I've had contact with people from the Kentucky Academy of Family Practice, some obstetricians, gynecologists. If we could have a larger work group, I think we could make some compromises, possibly.
And could I?
And I know that the KBML is, they have to be frustrated continuing to talk about this. But I keep going back to the fact that, members of this committee, they don't know what you all know, and we haven't had the experience that you have had. And thank you for sharing your story. It was quite compelling and dramatic, and I appreciate you opening it up and talking to us about that. But, I wondered if there was a way that we could have some compromise and conversations, because it doesn't seem like anybody's really happy right now with what's before us, and that's unfortunate. And
can I add one thing real quick? I think
Sure.
That there are some things in the current regulation that haven't even really been addressed, and I think we're somewhat of an oversight. I think particularly with like the paramedic use of buprenorphine, I think that really needs to be included in the regulation, something to specifically address that. And as it stands right now, I don't think there's enough clarity, and I think it's a major gap in the regulation. And I think allowing maybe emergency medicine and paramedic groups to have some say on any revisions would be helpful as well.
Thank you. It would be unfair of me not to allow KBML to come back up and respond briefly. So if they would, thank you for your presentation, excellent presentation. If you guys would come back up, we are running really short on time, so if you could keep it to 4 or 5 minutes maybe, if possible.
I'll jump in while they're sitting down. To the last comment, we can't regulate paramedics in our regulation because they're not our licensees. So that's not an oversight, that's an impossibility. Why would we put that in there? I can't regulate a nurse, they're not our licensees. This is specific to our licensees. To your point, Senator Adams, about could there be further compromise? This was the whole discussion we had with Representative Moser and these same persons who are sitting here at this table today at the end of August before the Labor Day weekend. And we deferred it from your committee so that we could get very specific feedback from them about where those compromises could be. We got a joint statement. I'm assuming that is what you have that you referred to, that is dated September 4th. Most of that statement is repeal. That's all it is. We are not inclined to repeal it. The two substantive specifics that they did make suggestions on are the agency amendments that are before you today. We have added the exemption for transfer via monoproduct for up to 30 days, and then we've also included the ABMS specialist as qualified to have patients referred to them for a specialty consult. So we did do that. CISAM was given the opportunity to submit a separate letter under a separate cover of specific changes. They declined to do that. They said they were going to stand behind the ASAM joint statement. We've looked at that. We have a board of multiple practicing clinicians. Every time we have a board meeting, we have to pull them out of clinic to get a quorum to review these things. I strongly suggest that we not defer this any further. It has been 2 years. We all recognize we have an outdated regulation. It needs to be updated. That's all I'll say about that. I am going to let, though, the clinicians address some of the statements that were made here about the clinical side of this practice.
Dr. Mark George, and I could share my CV with you if you wish, but I won't. I've worked with the Board of Licensure, and I will make this very brief. Everybody has promised that. My role as a consultant has been twofold. These regulations have gone through multiple iterations over the past 10 years or so. I've been involved in every single one of those. There have been changes each and every time, updating them to evidence-based medication, use of this particular medication, and the practice of this. My other role has been to review complaints about physicians specific to the prescribing of buprenorphine through the Commonwealth. I see what happens in this Commonwealth, how these physicians practice or fail to practice good medicine, but particularly good addiction medicine. And there need to be some guidelines to show them. These are just standard guidelines. Yes, I feel very much evidence-based that can show the physicians how the practice is. But we forget, and Dr. Thornberry mentioned Section 4, there definitely is opportunity in an individualized way for a practitioner to be able to prescribe buprenorphine outside of these standards. You just need to be a good doctor and document what you're doing and why you're doing it. And those are the failures that I see out in the practice. I also agree with Dr. Thornberry that this is Kentucky and not the rest of the United States. This epidemic is very different. Dr. Ryan mentioned the overdose. There's no question that the prescribing of buprenorphine and other medications for opiate use disorder play a significant role. And I think that the fact that we are accessing buprenorphine more, agree with Dr. Thornberry, it's not only the patient, it's the physician. I don't think physicians are very much interested in treating this medical disorder. It confuses them. They don't know. They think they don't see these patients, but they see them very regularly, yet defer that practice. We have telehealth now, and I agree that in the rural settings, it's very difficult sometimes to get appropriate, adequate access to care. But we do have telehealth, and I think organizations like the Kentucky Society of Medication could use their energies to get their members to better prescribe both in office as well as out of office. We don't kick patients out of treatment. We do ask them to get involved in behavioral modification. That does not necessarily, I think this is just some difficulties in interpretation. That doesn't mean you need to go to a psychiatrist or you need to go to a mental health specialist. When I meet with a patient, I am giving them behavioral modification each and every time that I meet with them. And I think that this is a crucial aspect of treatment, and the practitioners need to be willing to do it. Lastly, I'll say, as far as the urine drug screens go, I don't see how one can practice addiction medicine and understand where a patient is without getting urine drug screens. Yes, it's costly. And we've seen outside in the community here the co-prescribing of benzodiazepines, gabapentin, now a controlled substance. These are dangers. This is not an innocuous medication. It's very safe. But particularly with co-prescribing, we see the dangers that can develop not just to the patient themselves, but to the entire community. So I thank you very much. And
firstly, I'm empathetic to the committee. You've been dragged into this, and I apologize that it's set on your shoulders today. I'll be extraordinarily brief. And there's a couple of important comments that I have to make here, because there's been, if I was up there, I would not know how to make sense of this. I want you to understand we've had 20 meetings at the board that have lasted 4 and 5 hours apiece. They take another hour or two to set up. I do not work in addiction medicine. I did pretty well in medical school. I got a big long list of credentials too, and I know how to read journals. And I got 4 people that are exceptionally good at addiction medicine that we bring in there because we trust them. We've gone, not just here, we've gone around the state from Pikeville to Paducah. I've spoken to large providers, small providers. I've spoken to people in every different state around us to find out what they're doing, to try to get as big of an idea of what might be appropriate. There's a very loud contingent of people that do not believe we need regulation on this, and they want it repealed. The board does not believe that. Eventually, that's what it's going to come down to. You've got to decide whether you're going to which bucket you're going to move into. I will tell you that and I'll make this perfectly clear for anyone that has any misunderstanding, because I think there's an awful lot of misrepresentation that was made here. The board wants every person and their family that needs them treatment to be in treatment, without exception. We can only imagine, and personally, I can only imagine one person that cannot receive treatment in Kentucky. That's somebody that comes in with repeated negative urine triage that has no Suboxone. And that tells me that they're diverting this drug. If you come in and you have Suboxone and an opioid, we're going to treat you. If you come in and you have methamphetamine or cocaine, we're going to treat you. We're not going to throw you out of clinic. We do not do that. That's not what happens. The reason we do urine drug triage is we don't do it to a patient. We do it for the patient. These people sometimes have no social support. They are broken people. They cannot tell the truth sometimes, and sometimes they're in a position where they feel like they can't be honest with us, and we have to look to see what other drugs are in there. What do we need to help them with? We're using it to get help, not to throw them out of clinic. The reason Suboxone is a Schedule II is not a Schedule II is only because it needs access for care. It has a substantial amount, and it was designed to have a substantial amount of withdrawal, and you need to understand that. The same drug companies and industries that put us into this position are making this drug. And what they do is they make a drug where you have to have the drug, because if you don't have the drug, you're going to have a withdrawal. And that's why they come back. Also, the drug is diverted because what they do with the drug is people divert this so that they can use it with the benzodiazepines and other drugs to get high, and they don't have as much anxiety or withdrawal coming down. So this drug is diverted. It's an extremely safe drug, but not with other drugs. Here we're trying to educate you in 20 or 30 minutes. It takes decades to understand this problem. And here we have a very difficult time. The board is trying to do the very best it can with try to have some firm regulation for oversight to help our clinicians, but people are not prescribing the medicine because of the regulations. It's because these patients are very complicated, and we're trying to help these clinicians. Again, most of which you're looking at a bunch of doctors today. Most of these people that are prescribing it have no MD at all. They have very, very little. Some of these people, they just have a white coat and a pen. And what we're trying to say is, instead of just putting people as a drug dealer on the street and a drug dealer in a white coat, we're trying to say we're not going to become that drug dealer in a white coat. We need to do things to try to help these people and their families. We need some guidelines for these clinicians. I mean, there's a litany of things that I think are just completely misrepresented to you guys, but my goodness gracious, it would take all day to go through it. We have a complete section 4 that says if you want to do something as a clinician, you can do what you need to do. Just document it so we can understand what you're doing. But remember when I told you that only 3% of these people need milligrams over 16. What if you had a clinic where everybody's getting, say, 30 milligrams? Wouldn't that look a little strange? Well, we don't have any regulation, then somebody could come to us and say, and they do come to us saying, well, look, we think that we're doing the right thing. Look at some nebulous guideline. It's a license to say whatever you want to say. And that's what happens to us. We get people coming into the board that are not doing the right thing, and they end up before us. And then we have to have something to say, well, what's kind of a reasonable standard of care here for the Commonwealth? I would implore you to consider the fact that this committee, I don't expect you to be physicians, but I don't see how the regulation we have is deficient. We've had this for 10 years. We're trying to make as much relaxation as we can based on the science. And again, we've given on almost every single issue. There's a couple of small issues here that we have not.
Could I pause you for 1 second? Hold that thought. We have to conduct a little business. Sorry. I apologize. Senator Adams almost made it out the door, and we couldn't allow that to happen. If you could come up here just a second real quick.
Well, I think that's probably, we ought to just truncate here, but I would say that again.
Just hold that thought. I'll come back to you.
Yes, sir.
Okay. Committee will stand at ease. I'm sorry. I am going to have to cut you off. Okay. And we're attempting to maintain a quorum is what we're doing. So you know how that goes.
And just for the committees to understand, when we have a quick meeting, we're only having a meeting to get this product in front of you. The decision was already made, right? We got a quorum. We moved this forward, so we would give you, it wasn't there to discuss the bill or discuss the work. It had already been accomplished. So we had an emergency called meeting to pull people out of clinic to have enough to get this to you on your desk. It wasn't because we intended to discuss it. We don't have secret meetings on the board. We discussed this every single time over the last 2 years. At every board meeting, it's been an open discussion to the public.
Sure, absolutely. Excellent presentation on both sides. Thank everybody involved. We do have a request here, and I know this is a difficult request before I ask it, but there is a request. Would you consider deferring it for one more month and coming back here and giving it one last go? So I'm going to just be out front. Would the agency be willing to defer this regulation?
I'm going to ask for some specifics about what we are deferring it for. If you want us to hear additional commentary about rescinding this regulation, then no, we politely decline. If you have some specific guidance other than the two things that ASAM has already given us and CAISAM has declined to give us additional guidance, please let us know. Passing this today, we can still receive those comments, and if it is something that needs to be updated in the future, as you will see from the history of this regulation, we open it up periodically. We first made it in 2015. It's been opened up 5-6 times since. Mm-hmm. So that's not an impossibility to continue to have that conversation. But what we have on the books now is an outdated regulation. It's been outdated for 2 years. And if we're going to go back around this merry-go-round of rescinding this regulation, I say we politely decline. We would like vote.
Okay. So my request, unfortunately for me, I have absolutely no control over how those meetings would happen or occur or what would be said. So my request, it would be a generic request. It's simply yes or no. My hope is that maybe after the discussions today, there would be some possibility of compromise, but I can't guarantee that. So now I understand your position. You have a hard and fast position. We're not going to rescind. We're not going to agree to that, which a deferral request doesn't mean you have to agree to that.
Okay.
And I'm not asking that personally. But if you agree to deferral, I'm asking for continued dialogue with the other groups, simply put. So,
right. And that dialogue does not cease just because we
sure,
decline to
absolutely.
defer.
And we have another committee jurisdiction beyond this.
Exactly.
But the reason we're even asking for this is we realize how very, very important this decision is. And it's nothing against what you've already done. I congratulate you for the steps you've taken. But as was said, we need to get this right. You only get so many bites at the apple. And you do have the other aspect of we go into session in January. So interested parties, educated people will have their own opinions once we get in January on how the regulations should read. So all this could be a moot point anyway once we get into session also. So just a thought. I know it's difficult. I know you've had a ton of meetings on this already, but it is another effort at compromise. And if you're unable to compromise, then
I would just like to know what guidance for the compromise that we need, because the only thing I
have
heard
no
today,
guidance.
because you sat here and heard the same things that we heard. I got no specifics about other than that we didn't include paramedics who we don't regulate, but
well, ultimately that would be
that
would be the responsibility of the other side to offer a compromise, right?
Okay.
Right.
A deferral request is in no way an obligation to accept the demands of the other side. It's just a step, another step towards compromise.
Yes.
Mr. Chairman, I think what we'd like to do is we'd like to work with you and the committee to try to help our colleagues come together if we can. Okay. If you'd like us to defer this, we've done this for 2 years. We will certainly do it in good faith. I want the committee to understand, and I understand how politics is. We have come this far. Mm-hmm. This family of thought has not moved at all in 2 years. They've done nothing.
Sure.
They have not moved a bit. And so that's why we're in a position of, it makes it very difficult when we've come this far. We really are at a position of how much further we can go. I would be happy to bring it back to the board, and we'll do our very best to work with our colleagues, but we need some constructive dialogue as to have them work with us on what it is that they're going to acquiesce on, or how is it they're not seeing our position in these areas.
I can tell you this. I can't, if you agree to, if you say yes, you can talk to our attorneys, and we were more than happy to work with all parties, and we can be a go-between. I'm volunteering our people to be a go-between, and we can agree to that. Okay, so we have to do this procedurally so we can get Senator Adams on the road here. I make a motion for deferral. Is there a second? Without objection, is so ordered. The regulation is deferred. Thank you so much. Got a couple. Thank you so much. We're going to switch gears here real quick. We have 2 agency amendments we need to deal with quickly. Board of Social Work, KAR 201-23075.
201 KR 23075 amends provisions related to continuing education for renewal. The agency amendment amends to delete section 29 for consistency with statute.
Is there a motion for approval of the agency amendment? We have a motion and a second without objection, so ordered. One more, Senator Adams. Cabinet for Economic Development, 307 KAR 1080.
307-1080, an emergency, establish the Kentucky Entertainment Incentive Program. The agency amendment makes changes consistent with the emergency amended after comments version.
Motion for approval of the agency amendment. Second. Motion. We have a motion and a second without objection, so ordered. You're good to go. Sorry about that, guys. That business done first. Committee will stand at ease. One moment. Okay, we can breathe now. So I'm going to call the Board of Social Work back up. Or they're still here. Okay. I totally apologize. It's somewhat disjointed here today. If you would, whenever you're ready, state your name for the record. Green light.
Mark Kelly, Executive Director.
Mark Bringelman, Mark with a K, Contract Counsel.
Very good. Do we have any questions from members of the committee for these gentlemen on the Board of Social Work? Thank you. We've already taken care of the agency amendment. We're good to go. Thank you so much.
Thank you.
Now we're going to come back to the Cabinet for Economic Development.
Economic Development, 307 KAR 1080, and Emergency Ordinary has agency amendment.
These administrative regulations establish the Kentucky Entertainment Incentive Program.
If you would, state your name for the record.
Yes, Matt Wingate, General Counsel with the Cabinet.
Thank you so much. Are there any questions from members on these regulations as amended by the agency amendment? Seeing none, thank you. Appreciate it. Here. Kentucky Teachers Retirement System.
Kentucky Teachers Retirement System and Department of Revenue. We are calling everyone together, 2 or 3 at a time. Please come when your cabinet or agency is called. That is 102 KAR 1175 and 103 KAR 2005.
102 KR 1175 removes language that required the Board of Trustees to conduct a real estate purchase on a triple net lease basis with an outside company. The Department of Revenue Reg 103 KR 2005 amends the life expectancy table used when computing the value of a beneficiary's life estate, annuity, remainder interest, or other interest in estate based on life expectancy.
Would you state your name for the record?
Bo Barnes, Deputy Executive Secretary and General Counsel for the Teachers Retirement System.
Thank you. Kim Hensley, Division Director at Department of Revenue.
Bethany Atkins Wrights, Counsel for the Department of Revenue.
Any questions from members on this set of regulations? Seeing none, please call the next regulation. Thank you.
Thank you.
We're calling the Boards of Nursing, Physical Therapy, and Medical Imaging and Radiation Therapy. 201 KAR 2161, 162, and 410. 201 KAR 22020, and 201 KAR 46010 and 081.
201 KR 2161, 162, and 410, amend provisions relating to investigations and dispositions of complaints, disciplinary proceedings, and record expungement. 201 KR 22020, amends to change exam failure provisions, delete test score requirement, and add requirements for credit by endorsement. 201 KR 46010 and 46081, make changes for consistency with House Bill 72 from the 2025 regular session related to definitions and limited X-ray machine operators.
If you would, state your name for the record.
Kelly Jenkins, Executive Director, Kentucky Board of Nursing.
Jeff Prather, General Counsel, Board of Nursing.
I'm Carson Kerr, Legal Counsel for the Kentucky Board of Medical Imaging and Radiation Therapy.
Stephen Curley, the Executive Director for the Kentucky Board of Physical Therapy.
We started slow, but we're moving really fast now. Any questions for this group of individuals on this set of regulations? Seeing none, please call the next regulation. Thank you.
Thank you all.
We are going to be calling Department of Fish and Wildlife Resources and Transportation Cabinet 301 KAR 115, 125, 132, 140, 152, 155, and 185 to 031, 041, 081, 082, 083, 178, 195, and 230, 3, 120, and 150, and 4, 070, 090, 100, and 5, 001, and 002, as well as 601 KAR 23070.
One correction, 301 KAR 5022.
This package of fish and wildlife regulations revises provisions related to fishing, hunting, wildlife, and licenses. 301-5022 revises fees.
601 KAR 23070 establishes procedures for street legal special purpose vehicles on designated public roadways.
Would you please state your name for the record?
Gabe Jenkins, Deputy Commissioner, Fish and Wildlife.
Jenny Gilbert, Legislative Liaison for the Department of Fish and Wildlife.
John Johnson, Assistant General Counsel, Transportation Cabinet.
Thank you so much. Don't get used to this. Don't get used to this. Any questions from members? This set of regulations. Seeing none, please call the next regulation. Thank you.
Kentucky Community and Technical College System and Department of Workplace Standards 739 KAR 1080 and 803 KAR 2120 Emergency 181 250 260 and 310 Emergency.
739 KAR 1080 establishes that the KCTCS Board of Regents elects to issue bonds in accordance with KRS 164A 605.
This package of workplace standards regulations revises provisions commensurate with federal standards and House Bill 398.
Would you please state your name for the record?
Todd Kilburn, Senior Vice President and Chief Financial Officer for the Kentucky Technical and Community College System.
Chelsea Young, Counsel for KCTCS.
Dondra Meredith, Deputy General Counsel, Education and Labor Cabinet.
Robin Maples, OSH Standard Specialist for the Department of Workplace Standards.
Good evening. Afternoon. Chuck Strebling, Deputy Commissioner, Department of Workplace Standards. Sorry, I just had to do that.
That was funny. That was good. Any questions from members? This set of regulations. Seeing none, please call the next regulation. Thank you.
Public Protection Cabinet 806 KAR 2200, 210, 220, and 20030 Emergency and Ordinary, and 810 KAR 6001, 7060, and 080.
806 KR 200, 210, and 220. Implement House Bill 256 from the 2024 regular session relating to the Strengthen Kentucky Homes program, including operations, eligibility and grant procedures, eligibility requirements for contractors and evaluators, and re-inspections. 806 KR 20030E and O establish the car evaluation guides as required by Senate Bill 136 from the 2025 regular session.
This package of horse racing regulations update definitions. Pursuant to House Bill 566, differentiates the Kentucky Quarter Horse Development Fund as its own fund and raises some fees.
Would you please state your name for the record?
Sean Orm, Executive Advisor with the Department.
Russell Coy, General Counsel, Department of Insurance.
Hi. Good afternoon. Jamie Eads with the Kentucky Horse Racing and Gaming Corporation.
And Ashley Bailey, Chief Legal Officer for the Kentucky Horse Racing and Gaming Corporation.
Thank you so much. Any questions for these individuals? Seeing none, please call the next regulation. Thank you.
That concludes our agenda for today,
Except
that is my bad.
Regulations for Informational Review, the Board of Emergency Medical Services, 202 KAR 7401, 410, and 701.
202 KR 7401 establishes requirements and procedures for licensure, relicensure, and reciprocity of paramedics. 202 KR 7410 establishes the requirements for advanced practice paramedics, including the scope of practice for varying types of paramedics. 202 KR 7701 establishes the scope of practice for individuals certified or licensed by the Board of Emergency Medical Services.
if you would please state your name for the record.
Eddie Sloan, Kentucky Board of EMS, Executive Director.
John Holder, Chairman, Kentucky Board of EMS.
John Wood, Outside Counsel, Kentucky Board of EMS.
Thank you so much. Today is not your lucky day. We had to take care of some business earlier, but this set of regulations is set up today for informational review only, and this request is in relationship to the media reports on the snake situation. And if you could just speak to that and help guide us through a possible solution. That's the effort we're trying to make today. So.
Sure. I would like to start, and I think in full accuracy, that we should say that this is best not played out in the media, that in full fairness, that's...
we never experienced that.
Well, I understand, sir. I'm sure you have some empathy for that. But the scope of care, first of all, the scope of care is developed through the National Highway Safety Transportation. That's kind of the birth of EMS in Kentucky, or across the nation, not just Kentucky. And so really hasn't moved out of there since the 70s. So they present a guidance document that talks about for each of the level of providers what that scope of care may look like. It's a guidance document. Then our board takes that. They look at that. It starts in medical oversight. Medical oversight's made up of a group of different individuals that are, 3 of them currently are emergency room physicians, 2 of which are either a paramedic now or have been a paramedic in the past, a nurse practitioner who is also a paramedic, and then 2 other paramedics that look at the scope of care and kind of take that scope of care and make a recommendation to the board. I would say that as you look at the scope of care, one thing that's really important to remember is we look at the scope of care as to what's likely to happen. We can never pick out every specific instance. And when you talk about antivenom, because that's kind of what you've asked us to speak on, we spoke about native snakes in Kentucky. We didn't really think about snakes that are found in South Africa. So in fairness, when we talked about antivenom in our scope of care, I recently spoke to a UK physician and asked him, and he advised that about someplace under 10% of all snake bites native to Kentucky end up getting antivenom. So when the scope of care was developed, it was developed in a way that in most cases, it's a wait-and-see approach. Then add in the factor of the expense that it would be to carry the antivenom, the number of snakes, which EMS in Kentucky has transported 34 confirmed venomous snake bites thus far this year. So it's a relatively small number of the 960,000 we make. And none of those, with the exception of the snake that's not native to Kentucky, were in distress upon their transfer of care to the final facility. But to answer your question, what could we look at in the future? One of the things we've looked at is what we'll call an exception protocol. And that exception protocol would need to come with something that you just can't be the exception because you show up and someone at their house says, I'd like for you to treat me this way. But if they have a condition or if they have a special event or whatever that makes their situation unique, their physician or some guidance document would be presented to the care provider that says, this is really unique. This is a trial medication. This person is 1 in 20 million people or whatever the case may be. And here's how you should treat this person. So they would give you almost a just-in-time protocol. And we would have an exception that they could use. Then you would take that exception, you'd reach out to medical control, being an emergency room physician, say, this is what I have before me. This is the recommendation I have before me from this person's physician or trial case or whatever it may be. We would like to proceed with this scope of care. That's what I think you will see our board take up in the near future, at least for consideration.
Could you go into a little bit more detail about how that would work? Like, who holds the paper, or how is that mechanically done?
I think probably when we're speaking of exception protocols, it would probably be the provider. You know that you're, for lack of a better term, a special case, let's say. Let's say I'm on some experimental drug and I have a fall and we have to have this antidote to reverse the medication I have or whatever the case may be. So it really isn't practical. You know, you may be the only citizen in Kentucky that needs this exception of care.
Right.
Now, the other thing that I would point out, and I'd be happy for anyone else to respond, but that we would point out that if someone comes to the board, there's always the opportunity if someone comes to the board and says, we have something that's really unique in our community, we would like for you to explore this protocol that could be an exception for us, we would look at that. And while we could talk about the antivenom, a better scenario may be the weapons disposal that takes place in Madison County. We recognize they're in a unique situation that's unlike most of the rest of the state of Kentucky.
And if I may, real quick, just a quick point of clarification, just so we don't get confused. There is a level of paramedicine in the state of Kentucky that allows the administration of antivenom. So I don't want it to appear as though, as a paramedic in Kentucky, you can't give antivenom. As a baseline paramedic, that is true, but there is a specialty training of paramedic that can give antivenom. So that actually does exist currently.
So let's take the situation at hand. And first question, would this be done through a new regulation? Theoretically, is that what you're thinking?
I think it'd be done through protocol changes. So the way the protocol system works is each individual agency brings their protocols to the board for approval, and then those
so you wouldn't need a new
protocols
regulation to do what you're thinking about doing?
I don't think so.
Okay,
No.
so apply that. I'm a little slow sometimes, so you got to bear with me. So apply your logic to the situation at hand that was in the media. The gentleman has a snake bite with a very rare snake. How would his case have been handled under this new protocol?
Certainly. Ideally, in a special case like this, you would recognize I've got a venomous snake farm in my community, for lack of a better term. You would think perhaps we need to lean forward on treatment of care for that kind of thing. You would approach the board and say, hey, we would like to have this specific protocol to treat this specific thing in our community. We would then run that through the medical oversight committee that Eddie just described to assure safety of the citizens, and then it would come to the full board for a vote it would come through the medical advisor and then the full board for a vote to approve that.
Thank you. Any other members have questions on this topic? Fantastic. You gave us exactly what we wanted. Sounds like you're working on it.
Yes, sir.
You're working on a possible solution. I would request as chair that you would just keep us informed about where that is and how it would progress. How long do you think it may take?
I would like to tell you be quick, but I think realistically 4 to 6 months.
4 to 6 months. Okay. At least we have a target. That's fine. Any other questions? Seeing none, thank you so much for your presentation. We really appreciate it. Sorry you had to wait till the end.
No problem.
Happy to help.
Anybody have anything else? The next meeting date.
Because of Veterans Day is the Tuesday the 11th, our meeting is scheduled for Monday the 10th, November 10th at 1.
Okay. There's nobody here to comment anyway, but we'll look. Good for me. Everybody good?
I just want to thank whoever left this little tree.
Yes. Thank you.
It's great. Thank you.
Our staff did an excellent job today. Thank you for all the changes. Seeing no further business to come